Hello and welcome to Beyond the Badge. I'm your host, Middlesex Sheriff Peter Koutoujian. Today we'll be focusing on a broad range of issues related to the Executive Office of Health and Human Services, the Commonwealth's largest secretariat. Few entities in state government have the power to positively impact as many lives as the Executive Office of Health and Human Services, or EOHHS as it's called for short. As we continue to fight a growing opioid crisis, EOHHS is on the front lines, but the agency and its employees are responsible for much, much more. Joining me today to talk about those responsibilities and the work of EOHHS's 22,000 employees is Secretary Marylou Sudders. A trained social worker, Secretary Sudders served as the Commissioner for the Department of Mental Health from 1996 to 2003, headed the Massachusetts Society for the Prevention of Cruelty to Children for nearly a decade, and has served on the boards of numerous charities and nonprofits, including the National Alliance for the Mentally Ill. She was appointed Secretary of Health and Human Services by Governor Charlie Baker in 2015, and I'm proud to call her a longtime good friend. Secretary Sudders, thank you so much for joining me today.
Thank you. It's my pleasure to be with you.
Well, it is great to have someone as notable as you in charge of the largest secretariat in the Commonwealth, 22,000 employees, but I don't think many people really understand the breadth of what EOHHS does. That's easy for you to say. Every day, affecting the lives of tens and hundreds of thousands of people every day. Could you tell us a little bit more about what you guys do?
Sure. It's a privilege to be with you today. So EOHHS touches the lives of 1 in 4 residents of the Commonwealth of Massachusetts.
That's about 1.5 to 2 million people?
Yep,
Wow.
1.8, 1.9 million people in the Commonwealth. Medicaid alone is probably the largest part of Health and Human Services, right? The public insurance program for so many people in the Commonwealth, including individuals who are incarcerated either coming in or out of jails and the like. But in addition to that, we're responsible for child welfare, the Department of Children and Families, as people know it, public health, mental health, juvenile justice, the disability agencies, people who are deaf and hard of hearing, Mass Commission for the Blind, and developmental services, to name just a few, plus veteran services, so important to us in the Commonwealth. We have probably the best veteran services in the United States in terms of supporting folks who've served, and elder services. So it's really that broad band of health and human services that touch so many people's lives.
Now, you were the Commissioner of the Department of Mental Health for a period of time, and we used to do a lot of work together back then, and that was always wonderful to see you in there. It was a great pleasure to see you appointed as Secretary. So you run a relatively large, complex agency. Now you're in charge of many of those agencies as the Secretary. What's the role difference in being Secretary versus being a Commissioner?
You know, that's a great question, because when I was appointed by the governor, I thought, I know public service. This is actually my 4th paid return to public service. It is completely different. As commissioner, you have line operational responsibility in addition to services and supports and running facilities.
So direct management of individuals, right?
As secretary, in some ways, I'm almost like a portfolio manager. So I set the strategic tone for all of the agencies, all 12 agencies within Health and Human Services. We're all about health, resilience, and independence, and charge the agency heads for operationalizing that. And so I engage with them on much more strategic and tactical issues rather than day-to-day management.
So it sounds like you're almost a little bit less control, more responsibility too, though.
More authority, less control, and less day-to-day management. But I think agency heads would say I'm a very active secretary.
I would imagine so. I would imagine.
And people treat you differently because you're one of 7 or 8 people who report directly to the governor. And I have noticed that people I've known for a long time are a little more deferential, even though I still think of myself as Marylou Sudders.
Right. Yep. And I think earlier you were speaking a little bit about you're not exactly in control of your own schedule as a secretary. You'd think you'd be, as a sheriff, I noticed this too, you'd think you'd be more in control of everything. In many ways, you're more reactive, responsive, aren't you?
You actually have less control of your schedule. That's been probably one of the funniest surprises, which is everyone controls my schedule apparently but me. And you're at a lot more public events and really representing the face of Health and Human Services. And hopefully ensuring the public's confidence.
I think that's right. That's a really important part of what we do, is to let people know about good government at work, because they always seem to hear about the bad government at work. It's important for us to let them know how government can work for people, right?
Absolutely. Again, 1 in 4 lives of the Commonwealth of Massachusetts, and the only thing we really ever see are the headlines that hit page 1 of the Globe or the Herald.
Yeah, and honestly, I'm a big believer in putting out the good stuff that people are doing. I will say also that I do know when people are calling me or asking me, hey, can you speak here? Can you be there? And I'm like, just call my office. I don't know. They say, I don't know. Just call my administrative office and ask them, because I'm not really sure. I can look at my schedule quickly, but I'm really not in charge of myself anymore.
Nope. I say, if my scheduler knows, I'll be there.
That's right. That's right. That's right. If they say I should be there, I'll be there.
Absolutely.
Right. Listen, the governor, one of the things that we've been working on a lot, and we've spoken on a couple of pretty notable panels actually together, one at the Kennedy Institute, one at Roxbury Community College. I've seen you speak in many other places. The governor has really made the opioid abuse problem in this state a primary effort of his, which I really applaud him for. This has been going on for 10 years. Yeah. I served on the first OxyContin Commission report 10 years ago with Michael Botticelli, who's now the National Treatment Czar, which is pretty amazing.
It's nice to have a friend in the White House who's so focused on this issue.
It's really amazing. And actually just watching him in some of the hearings recently and on 60 Minutes, he's really doing so well. Yeah. The interesting part about this subject matter is evidenced by the fact that you've got a governor and a Republican governor, Democratic sheriff, and many other Democratic and Republican sheriffs working together on this, is the fact that this issue is not a partisan one. To both parties or anybody that's not part of a party, it's the same problem. And he's really focused on this. Can you tell us a little bit about your experience with how he came to this effort and how you have been working together?
Sure. As the governor has said, he certainly didn't run to become governor on the opioid crisis in the Commonwealth. But as he was running, it didn't matter where he was in the Commonwealth of Massachusetts. It could be in a backyard, someone's house, at a speaking event. Someone inevitably would ask, could they just talk to him about their son, their daughter?
Even on the side, a little private conversation, right?
And the more as he said, he needed to learn more about this opioid crisis. He understood heroin, but he really didn't know. And the more he learned, the more frightening it became. I mean, it's really terrifying. It is an epidemic. We call it what it is in the Commonwealth of Massachusetts. This is an epidemic. It has been on this negative trajectory for a number of years.
It's continuing the trend. There's been no interruption, despite the fact that everyone seems to be aware of it.
We have had a 225% increase in the rate of deaths since 2000.
Right.
It's 300 people died in 2000, and in 2014 it's just under 1,200.
That's right.
It's on this complete negative
it's
trajectory. So when he came in, he said, we're going to deal with this. We're going to deal with this crisis. He appointed a working group. As you know, I chaired it, held listening sessions. That's my social work, the social worker in me, held listening sessions across the Commonwealth and put together a pretty multifaceted plan, classic public health plan. Prevention, intervention, treatment, and recovery.
Right.
Multifaceted, multi-pronged, because it's going to take us quite a while to bend this trend.
And it seems, what I really appreciate in the leadership of the administration is the fact that it's personal to him without him having to have been directly affected by it. Yeah. He has made it personal because he has seen the loss for so many people, and I applaud the both of you for bringing forth a piece of legislation that is strong. I think it has been well said that we've been working at the edges of this for 15 years now. Yeah. The recommendations we made in the OxyContin Commission report in 2005 are as relative and valid, and many of them unfulfilled or not fully fulfilled today. And thus we've seen, back then there was just over 400 deaths. That was in 2005, yeah. Less even in 2000. 1,256 in 14 and more so now, and yet we're still not doing what we should do. So I appreciate the fact you've got a couple of things in there. You've got the limited prescriptions by the physicians initially. You've got a 3-day hold, which may or may not get through the legislature. I think it was a strong effort to put that in there. There was a Section 35 that we can speak about. Could you speak about a couple of these things, these elements to this bill?
So the opioid crisis is a great example of a Republican governor working very closely with the Democratic legislature, with communities across, as you say. This is like such a bipartisan issue. this touches everybody.
Right.
And we did believe, based on what we were hearing, that we needed to file a bold piece of legislation that we understood was disruptive, was meant to be controversial.
That's right.
You and I both know, since
Right.
you were a member of the legislature, what is usually filed is not what usually happens
That's
at
right.
the end.
You've got to push it. You've got to do a little harder line to hopefully
That's-
come up with something that you think is effective.
That's effective.
Absolutely.
Very pleased when the legislature, so right now the bill is in conference committee, and I have every confidence that the legislature will put out a comprehensive
Right.
bill that'll hit the governor's desk. But in the interim, the legislature did pull out a piece,
Right.
An issue you know well,
That's right.
which ends committing women to MCI Framingham for the treatment of addictions. These are women who've not committed any crime
Right.
and were civilly committed to MCI Framingham. We've said we were going to stop this practice since 1987, and I can tell you in 2016, we'll have stopped that practice.
Well, it's amazing because it's a matter of equity, really. The men were sent to a civil commitment, a place of civil commitment, which was secure, but it was a civil commitment place.
Yep.
The women were sent to a prison. And that's just a matter of equity. And it's amazing that it took this long to change that. And I applaud, because I know that piece was actually pulled out of the bill and passed
Yep.
by both legislatures. And the House and the Senate, and by the governor as he was pushing it through. So that's really great news. And again, kind of shines a light on the fact that even today, especially in the correctional field, there is a difference between how we deal with men and women. It's just a focus on the men. The more men, crimes are more. The crimes committed by the men are more notable. You just tend to focus on that. But now the percentage of women being just as involved is growing exponentially each year, and so we really do need to. And by the way, the impact that the correctional impact it has on women impacts more significantly on the family. Is 4 out of 5 women are primary caregivers of children, or 5 times as many women are primary caregivers of children. So it really impacts the family much more significantly.
So we were, as you know, the legislature had signaled that they were very interested in this issue. I started to actually create the beds at Taunton State Hospital even before the law passed, and because I just knew you knew it was going to happen.
Right.
And I'm happy to say February 9th, next week, is when the treatment beds will open at Taunton State Hospital.
That's
so
great
women
news.
can be.
Congratulations! That's a great day. That's good government at work right there.
It's long overdue, but
That's
you know
right.
what? It is a great example
Yeah.
of good government at work.
One of the recommendations of the task force, the opioid task force, was also the greater use of Medicaid for those that are justice involved. Could you tell us, that's something that we pushed for out of the Middlesex Sheriff's Office. My experience as the chairman of the Committee on Health Care made me hyper aware of an inequity in the system and opportunities in the system to provide health and hope and proper reentry for people that are justice involved. Can you tell us a little bit about what led to that? It was a nice piece in there, something that people wouldn't normally have expected. Really just went to show the thoroughness in the active engagement of this task force.
Well, as you have said so often, we can't incarcerate our way out of an opioid epidemic, and we've been trying to create the treatment portals for people to get treatment rather than going through the courts and jails in order to get treatment for addictions. This was for some people, a small piece. For me, it was a really important piece, which was individuals who are jailed needed to have access and quick access to Medicaid, both it's a technical term. We use it if you had Medicaid and you're incarcerated, you used to get terminated, and took quite a long time for you to get the Medicaid reinstated. So we've done, really working with your office as the lead, actually. You were our guinea pig to try to figure this out, and we're grateful for that, of really suspending people's Medicaid so that as they're coming out, we can quickly get them into treatment. The access is so important to try to prevent recidivism.
It makes perfect sense too. When you think about the fact that when someone is held on bail in jail, they would be terminated from their Medicaid, so that, and they haven't been convicted of a crime. I'm not saying they're all good people, but they haven't been convicted of a crime. And so for those, especially that might be too poor to make bail, but poor enough to qualify for Medicaid, they're terminated. And
Right.
and it wasn't just a suspension, as we're speaking about now. It was a termination. And when they got out of jail or got out of a sentence, then they had to sign up again,
Right.
and it was a 10-week lag time.
Yep.
And it just, and by the way, the issue of medical coverage is really important as we try to cover more people under the Affordable Care Act. That it shows medical, I call it medical recidivism, shows a significant, if you don't have medical coverage, you have a significantly higher rate of recidivism or reoffending than if you do have medical coverage, especially that with health care, but mental health care too, or behavioral health care too as part of it.
Yeah. So, Massachusetts has the highest rate of uninsured people in the United States, but we still have 3 to 4% of folks don't have insurance, and we know that people with
We
addiction.
have the highest rate of insured people in the United States, right?
Yes, we have the highest rate of people insured.
Right.
But we have 3 to 4% folks who don't have insurance. We know there's a very high rate of insurance for people with opioids and other addictions and behavioral health conditions. And so we really need to get this as low as possible. And obviously, folks who come in contact with the jails are people both going in and coming out that we need to make sure they have their Medicaid, if they're eligible, their Medicaid coverage to try to really get them into treatment as soon as possible. As we're working on it, as you know, it's not perfect yet. We're still working out some of the kinks in this. But since July, we have enrolled 3,000 people who've been incarcerated or pretrial.
And it hasn't been easy, but your office has been working hard, and we really appreciate that because I know it hasn't been easy, but it's really important. And the great thing too is if we can get them signed up for Medicaid under the new ACA affordability or the eligibility criteria, there's many more of these people. 3% of the state are uninsured, but 25% of our population are uninsured, so it's a significant opportunity to insure people. That if you can get them on, you can keep them on, and then you can actually then suspend them and then reactivate them if they go for an inpatient stay. People don't realize when they come in with us, if they have, for the first time, they're maybe getting some medical care, diagnosis, and treatment, and they're finding that people have significant health problems, cancers, and other life-threatening diseases that we have to treat. And when we send them out to a hospital, the state or the Middlesex Sheriff's Office is responsible for that bill, and they can be hundreds of thousands of dollars for some people. And so if we can actually get them on this, we can then get them to the proper payment method, which is a lot easier on the state, especially under Medicaid, and that's a great opportunity too.
It's good for the individual and it's good for the Commonwealth because we sort of then split the bill with the federal government.
It's good for the taxpayers,
It's
and
good for
honestly,
the
and under this, the federal government is paying much more, so the money is better used for Massachusetts as well. And speaking a little bit about the issue of mental health, let's speak about the State Without Stigma campaign. How'd that come to fruition, and what are its ultimate goal or goals?
Well, we think public awareness is a big piece to the opioid crisis. So this is our second public information campaign, if you would, and really targeted to stigma. Because just like as you and I both know, people with mental illnesses and people with addictions are so stigmatized.
Families, the whole families are. The communities are too.
The communities are, yes. Last week I went to a Learn to Cope, a family support group, and which is so important. It's also brutal when you sit with families holding their pain with them, and they talk about the stigma, and they talk about how they know if their family member had a medical illness, they'd be surrounded by their neighbors and other people with casseroles. And addictions and mental illnesses are not casserole kind of illnesses. They're so stigmatizing. So we've been, these are with federal dollars, so we get federal dollars available to us to do public awareness campaigns to really go to the heart of stigma and the acceptance that this is a disease, it's an illness, and we need to treat it as such. But you and I have been having these conversations for a long time.
And those stories are so powerful. I mean, most people that are watching this know someone that has suffered from addiction, especially now. But if you hear those stories, especially those parents that have struggled or suffered with their children, but then those as well that have lost their children, it is, I mean, I still remember from our commission hearings in 2005, I still remember almost verbatim, like a video playing in my head, so many of those stories of losses and tragedy and irreparable harm, something that stays with me today, and yet you still hear them today, and they're the same stories almost.
They're the same stories. I think what's changing, though, a little bit, and we tried to do this with the opioid working group, was to really call addictions what they are. which is it's an illness. It's
Right.
a disease. It is a chronically relapsing disease. This is not about lack of willpower. The addiction completely changes how you think about anything.
Right.
Not dissimilar to mental illnesses, that they just completely take over how you think, you act, you behave. But these are illnesses, and I think the more that we treat these as illnesses and get people into treatment and hopefully on the path to recovery,
That's right.
will
And
go
even
a long way.
on the criminal justice side of things as well, as you said, we can't incarcerate our way out of crime or a drug, epidemic that we treat. Listen, we in Middlesex Sheriff's Office, I'm really proud of the program we provide.
Yeah.
Matter of fact, Commissioner of Public Health is coming out to visit with us soon because we're trying to show what we're doing. Very proud of some cutting-edge, innovative, nation-leading programming that we're running as they're coming in with us and then as they're leaving through certain medically assisted treatment we're providing for them on the way out. Really special, and I'm really proud of it. But you shouldn't have to come to a place of incarceration to get that health, that care. You should be able to get it out in the community before you have to come, because serving time in a place of incarceration irreparably affects you. So you might be helped through a cure or some recovery, but it affects your ability to get a job, to stay with your family, to get certain benefits, housing, and so that can be irreparably harmed, thus leading you to recidivate again.
Right. Well, you have double stigma. You have the incarceration, right? So now you're a convict,
That's right.
So you have a CORI, and you have an addiction.
Yep.
You do provide wonderful treatment. I know that in the Middlesex jails, but really, what we need to do is really increase the access, the portals, so that people can get into treatment and not see the courts and jails as the primary treatment.
That's
And
right.
It's going to take us a while to get there, my friend.
We're getting there, though,
We are.
and your leadership is providing a great deal of that help as well. We spoke a little bit about the health care and the insurance as well, but some people have spoken about the bipartisan nature of the governor's cabinet. Sometimes criticized by certain parties, sometimes criticized by other parties, generally probably applauded by people in the middle. Those that just want government to work as it should work. It seems to be a very collaborative cabinet. I've really taken note this seems to be an empowered cabinet. Could you tell us a little bit about how that administration is working?
Sure. So I
And you, by the way, I just want to say I know that you could not work in an unempowered cabinet. That would not be a good match for you. You need to be empowered to be able to do what you need to do.
empowered, not necessarily
Yes.
power.
Yes, yes.
So I belong to the governor. I belong to the.
I'm sorry, I said empowered. I didn't say empowered.
I know.
Yes.
I belong to the governor. I belong to the Commonwealth's largest party, those pesky unenrolled, the independents. So I am the independent in the governor's cabinet, and many people would probably describe me that way anyway. But he has this really rich cabinet of Republicans, Democrats, and this lone independent. The conversations are really deep policy conversations. I don't feel the politics. I don't feel like this is a Republican issue or a Democratic issue. First of all, I'm incredibly pragmatic.
Yes.
And I would say that the governor is very pragmatic in his approach to government, which is he wants government to work for everyone in the Commonwealth of Massachusetts, and he certainly is committed to having Health and Human Services be as effective as possible for the 1 in 4 residents. So what I appreciate is the fact that the governor had been Secretary of Health and Human Services, so that when he and I are discussing issues, and a lot of them thorny ones, good things don't sort of happen generally in Health and Human Services. They're tough issues, right? Child welfare, Medicaid, costs, mental health issues, you name it. But the conversations are really deep policy conversations. I don't have to spend my time saying, mental health, and what I mean by that is da-da-da-da-da.
Right.
We just go deep.
Yep.
So it's really, it's very engaging.
Yeah.
But I've always been a public servant, even when I've not been in public service. So this is a tremendous privilege, and it's an awesome
It
responsibility.
must be a wonderful thing to sit at those meetings, but then also you can't sit there all day long and talk about these things where everyone's learning. It must be very engaging. But I know I've been in those types of meetings before, and you have to say, this is wonderful, but we've got to get on to other business too, I imagine, right?
Yep.
So what are those meetings like? Are they long meetings? Are they short meetings? Do you have an agenda you've got to move through?
The cabinet meetings are pretty tight. They're 2 hours once a week. and it is
Get your report out, get it
your
done,
report
move on.
out,
Yep.
a lightning round, and things that are on the governor's mind. He's out a lot, so things he's hearing,
Right.
he wants to put on the table.
Right.
Obviously, the fiscal situation of the Commonwealth is one that we're all very engaged in, and
Right.
that's a very active one discussion right now. But it's a lot of what he's been hearing out in the community.
Yeah.
But it's 2 hours, and then otherwise I engage with the governor and Steve Koutoujian, his chief of staff, on a much more, a lot of texting and a lot of quick emails back
Right.
and forth.
Right.
But then if I need him, he's there.
Right. You just mentioned the fiscal outlook. It's looking maybe not dire, but it's not looking great again. Resources going to be tight. There seems to have been laid out, at least by the House of Representatives, no new taxes, so we're not looking at that. I don't even know if the governor would be interested in that anyway, but finding ways to work with the existing revenues. How do you think that's going to impact EOHHS, but then other agencies as well?
Yeah. So for FY17, the budget that the governor just filed holds overall spending to about 3% in the Commonwealth of Massachusetts, and Health and Human Services comes in at 4.5%. So the governor acknowledges that Health and Human Services is a priority for the Commonwealth, whether it's child welfare, opioids have big growth, veteran services, homelessness, and my job is to ensure that we have a sustainable MassHealth program, which has been growing at double-digit numbers, was actually, as we were coming into office last year, I'll never forget this, was growing at the rate of 19%. Yeah, that was one of those. That was one of those moments. We have been able to curb the spending down to about 8.5%.
How did you do that?
So some of it's short-term fixes and long-term solutions. So some of it was moving some spending from one fiscal year into another by just, when you were going to pay the end of the fiscal year bills.
Right. Yep.
As I said to the governor, you can't reform MassHealth in 6 weeks. Thank you very much when we came in last year.
Right.
But part of it was also putting in what I would call better management controls. And I don't mean not having people have the access they need, but I think MassHealth was on such a growth trajectory, and because of the health connector failures, it sort of drew a lot of the MassHealth staff to helping to fix the connector that we're about back to like...
The controls were missed, basically.
The controls were missed.
Yeah.
So I had to redetermine the eligibility of 1.2 million people last year, and I thought, okay, we just step up and you do it correctly. I worked with all the advocates to make sure that people who were eligible for MassHealth did not lose their benefits.
Right.
And going towards the future, it's really about helping to manage people's care in a much more integrated way.
Right.
So 17 for us is the bridge with MassHealth, and the spending increase will be about 5%, which
that's
if we, even if we don't hit that exact target, of course, Secretary Leopold will say of Administration Finance, you better hit that target.
Right.
But if we come close to that, we will have started to really curb MassHealth spending without changing benefits or eligibility.
Right, that's great, and it seems to me that you're moving in that direction, that you're thoughtful, and you're being open and transparent as well. I think that, again, that the issue of transparency and in honesty is really important in government, because people can understand they might get hurt, harmed, or they might get helped, but if they understand why, they can accept it a little bit more easily too, and that you're trying to do the right thing.
I have. First of all, I believe in government doing the right things for people, but government also has to be effective, efficient, and open.
Right.
I can't fix every problem that comes to me as Secretary of Health and Human Services. I can treat the people who do come to us with dignity and respect.
Absolutely.
And that is just so incredibly important.
That's the most important thing. Well, I'd like to thank Secretary Sudders for joining me today and for her tremendous record of public service on behalf of the people of the Commonwealth. I also want to express a personal thanks for the collaboration with the Executive Office of Health and Human Services that has provided the Middlesex Sheriff's Office during her tenure. I know my fellow sheriffs, and I look forward to continuing to work with you, Secretary Sudders, as well. And thanks to all of you for joining us for this episode of Beyond the Badge Middlesex. I hope you'll tune back in for future episodes, but until then, remember, life is full of choices. Please make good ones.